In melanoma, over the last 5-6 years, we have the entry of 8 new drugs after frustration in stage 4 with no therapeutic progress. We have now targeted agents which recognize BRAF mutations, and we have immune oncology agents, checkpoint blockers, who have shown over the last years to prolong overall survival in stage 4 in the metastatic setting of this disease. This debate was based on a recently published article using the first generation of checkpoint inhibitors, a CTLA-4 antibody, Ipilimumab. And Ipilimumab was used, this adjuvant trial was started in 2008, using Ipilimumab as an adjuvant treatment in stage 3 disease of melanoma. Stage 3 is defined as disease which is confined to the lymph nodes. So there is metastatic spread to the lymph node, and a surgical procedure removing the lymph nodes is leading to tumor freedom of the patient, and then there is a certain risk for those patients to relapse, and this clinical trial was using Ipilimumab with a high dose, 10 milligrams, and the maintenance phase, and the second half of the study population used placebo, so closed observation. And the results have been published in October, demonstrating that patients who got treated with Ipilimumab had, after 5 years, an 11% increase in survival, from 50 to 60% survival increase. And the debate was whether it's worthwhile to use Ipi in this patient population, whether toxicity of the drug, and we had a few deaths even in this clinical trial, and we had 25% of patients who had severe colitis, which led to discontinuation of the drug. Whether this toxicity as well as potential costs of this treatment would block using this drug in the clinical setting. So the debate was set up in a way that 2 people were arguing for using the drug, and 2 people were arguing against using that. And I think we had a very interactive discussion, and arguments against for the use obviously is that patients who are alive at 5 years, we know that there's even a higher chance with also the newest drugs we have now in the metastatic setting to prolong survival even longer, so that there is a chance that these patients are also surviving 7 years and possibly 10 years. So there is definitely a fraction of patients who might be cured at the end or not dying of melanoma any longer. Obviously, the argument against would be that still 50% of the patients are already are still alive at 5 years without initial adjuvant treatment. And some of these patients are cured by the surgical procedure at the beginning already. And why should those patients be exposed to a toxic treatment for a long time? So there was a discussion on, can we identify potential patients who would benefit, which is quite difficult. There is no biomarker at the moment. There was a matter of, can we reduce toxicity by using a lower dose of Ipi? and treat only 4 times, as we do in the metastatic setting. We are giving Ipilimumab at 4 doses in 3 weeks intervals 4 times, and not as proposed in this adjuvant trial with 10 milligrams and maintenance for up to 3 years. So that's a severe difference.